Good day to you all. Welcome to this lecture on theories, models and frameworks for program design, implementation and evaluation. Before I start, let me take you to my landscape. In this picture you see one of the largest swamps in southern Finland. It's a nature reserve and there's a lovely hiking trail around the area. And I went there last summer with a couple of friends and my two dogs that you can also see in this picture. Most parts of the swamp are really wet and some are dozens of meters deep, so you have to keep on the duck boards. I thought that the photo showed some of the raw and wild beauty of my country, but also I find it a good metaphor to our topic today. I hope you will come to realize that in implementation research, theories, models and frameworks, or TMF, will be your duck boards as they will help to guide you throughout your project. My talk today has 4 parts. First, we will briefly talk about theories and why they are useful. The last 3 parts of the talk are organized by what I see as the 3 main functions of TMF: guiding the process, identifying and leveraging mechanisms of change, and guiding evaluation. But before we dive into TMF, I want to give a bit of a background to my career and how it has led me to specialize in theories, models and frameworks. I did my doctorate thesis in psychology some 20 years ago in a project evaluating participation in breast cancer screening as well as its psychological impact. The project was carried out at the Finnish National Public Health Institute in collaboration with the Cancer Society of Finland and the Finnish Cancer Registry, organizations that were responsible for implementing the national cancer screening programs. Although I later understood that my work had been implementation research, at the time I did not realize it as I knew absolutely nothing about implementation science. However, as I was finishing my thesis, my boss at the time, Professor Antti Uutela, asked me to write a grant proposal for a lifestyle intervention to prevent type 2 diabetes. This was to be part of a larger research program called the GOAL program to promote healthy aging in the Päijät-Häme province in Finland. At the time, my colleagues at the diabetes unit at the National Public Health Institute had just published the first results of the Finnish diabetes prevention study, a landmark study showing the efficacy of lifestyle change in preventing type 2 diabetes. The study had 5 lifestyle goals, and there was a clear relationship between the number of goals the participants achieved and the disease outcome. Among those who reached all the 5 goals, no one developed type 2 diabetes during the follow-up. The lifestyle counseling had been given by dietitians, and it was based on clinical experience, not explicit theories of behavior change. Furthermore, the trial was a typical RCT conducted in research setting with resources that did not exist in the routine healthcare in Finland. So we saw an important opportunity in showing that similar effects could be achieved in the real world with the nurse-delivered group counseling model that would require less resources and be feasible for implementation in the routine practice. Also, I had been active in the European Health Psychology Society, which was all about psychological theories, and especially behavior change theories, so I was very eager to put those into practice. I wanted our trial to be based on solid behavior change theory. We were lucky to get funding for the GOAL lifestyle implementation trial and also to have Brian Oldenburg as a collaborator. Without the study and the collaboration, I would not be here speaking to you today. Since then, we've translated the program in widely different cultures and settings across 4 different continents. First from Finland to Australia, then to India, South Africa and Uganda, and to Europe in Sweden, and most recently back to Finland, supplemented with the digital intervention. I will present the trials in India and Africa as case studies later during this school. With the GOAL program, our main objective was to replicate the findings from efficacy trials in the real world, but as said, I was very interested in the behavior change mechanisms. But also, as we started to plan the project with our stakeholders in the region's healthcare organizations, we started to realize how important the role of implementation would be. During the first years of the project, I really struggled with where to put our main focus. Was it on the participant level and their lifestyle change? The more we worked with the nurses delivering the program, the clearer it became that we were intervening on their level as well. And later, when questions related to maintenance and dissemination of the program started to arise, we realized we needed to intervene on the systems level. I'll talk more about these in another lecture on levels of intervention. So let's get to our main topic of today. Why are theories useful? First of all, theories help us to organize and understand complex phenomena, to interpret, to predict, and to make an impact. They can inform us on which level to intervene. Also, they point at determinants that we should target with our interventions and help to select appropriate intervention strategies. Finally, theories suggest what to measure and evaluate to find why our intervention worked or failed. We all have theories, but often they are implicit. We don't recognize them. For example, already during the GOAL program, but also later on, I found that many health professionals had an implicit theory or an expert script that they utilized also when guiding patients in lifestyle change. However, I've also found that the model that people actually follow looks very different. The same straightforward expert model also fails when it meets the reality of health systems in many parts of the world. Here a figure mapping the patient process in Uganda based on our Smart2D study needs assessment phase. You don't need to be able to read it to see that the process is not straightforward, quite the opposite. Patients bounce opportunistically back and forth between different community actors and levels of healthcare without any clear, proactively planned pathway. The reason why I showed you these two former slides is this. Taken together, they show that if you want to implement a program, in this case to help to prevent or manage type 2 diabetes with lifestyle change, you will need to consider all these three levels at least. The same applies to any other program relevant to healthcare, schools, work sites, or other settings. And for all these levels, you will need theories and intervention strategies. And to keep firm hold of all those levels, theories and strategies during the different phases of your project, you also need frameworks. I find it useful to think of theories and frameworks by their functions. Here I separate three functions that I think are the most important. First, to map or guide the entire process of your study. Second, to understand and leverage specific mechanisms of change. And third, to guide evaluation of effectiveness and implementation. Note that there are many theories or frameworks that tap more than one function. What I really want to emphasize is that you will need more than one theory or framework. You will need to cover all three functions. And if you have more than one level to intervene, which I'm pretty sure you should have, you will probably need different theories to inform on the mechanisms of change on all those levels. Throughout my talk today, I will share some important resources with you. And one of them is this web tool to implementation and dissemination models. If you are not yet familiar with it, I strongly recommend that you go and visit the site after my talk, but I think it's easier to use these kinds of tools if you have some sense of theories and models and frameworks already beforehand. One useful framework for guiding the process is intervention mapping. It will help you to plan the actual intervention as well as how to implement it. But also as an outcome, it will provide you with an evaluation plan. So this framework is equally useful for both functions 1 and 3. You start with the comprehensive needs assessment. Then you define the changes you want to achieve and their determinants, as well as methods to change them. In both these steps, you will need theories addressing the second function of TMF, which was the mechanisms of change. Once your program protocol is ready, the next step is planning for adoption and implementation, although in real life these steps are usually overlapping. For planning the implementation, you should follow the same steps over again, although on a different level or levels depending on your study. As an output of all the steps, you will also get an evaluation plan. One of the strokes of serendipity during my career was that I was starting to plan my first intervention, the goal program. I got to an intervention mapping summer school. I quickly realized the framework helped to organize our thinking and to put theory and practice together in a manageable way. Another framework that many find useful is the Consolidated Framework for Implementation Research. I have not used the framework myself, but I think it is especially good at pointing at the different levels that play a role in successful implementation, the characteristics of the intervention, the outer and inner setting, individuals, and the entire process. Also, it can serve as a great checklist. At the Consolidated Framework website, you will find these quite comprehensive lists of factors to consider for the interventions, as well as all the levels implementation process. This is from a recent review article on the use of the Consolidated Framework in low and middle income countries. They found that the framework was most often used as an evaluation framework, but I wanted to introduce it already here because I think it's worthwhile to consider also in the design and implementation phases. Another finding was that many researchers suggested that the health systems played a big role in the low and middle income countries and should be explicitly addressed in the framework. Social ecological model is another simple and good reminder of the different levels that you might need to consider. Finally, for the first function, I want to give an example of a framework for scale-up. The IHI framework for going to full scale outlines the 4 phases of scaling up an existing innovation. The first one, the setup. The second one, developing the scalable unit, then testing of the scale-up and going to full scale. It also outlines adoption mechanisms such as leadership engagement, communication methods, leveraging social networks, and building a culture of urgency and persistence that will enable progress throughout the phases. It also outlines support systems needed for scale-up, such as a learning system that connects adopters and experts, a data system and infrastructure such as IT and equipment, a capacity building program through training and support, and building a reliable process that supports sustainability. This framework is currently being used to scale up lifestyle interventions as part of the national hypertension and diabetes programs with the states governments of Tamil Nadu and Kerala in India. Now let's turn to the second function of theories, models, and frameworks, which is to identify determinants at different levels that need to be addressed, and selecting appropriate techniques for change in key determinants. Precede Proceed model by Green and Kruder can help you to identify key behavioral and environmental factors that need to change in order to achieve the changes in health and quality of life outcomes. It can also help to think about their determinants. When we started to plan how to translate lifestyle intervention to prevent type 2 diabetes in India in the Kerala Diabetes Prevention Project, we did a comprehensive needs assessment utilizing the Precede Proceed model. I will go through the findings in more detail when describing the KDPP as a case study later during this school. Often we also need to take a closer look at what the personal and environmental determinants actually are. Here, one option is to find a behavior change theory that fits well with your context. A useful guide into behavior and behavior change theories is this book, The ABC of Behavior Change by Professor Susan Mickey and her colleagues. When looking for a good theory, you want to make sure it fits your context and also fulfills these criteria of a good theory outlined in the same book. Your theory has to make sense. The concepts and their relationships need to be clear. You will need to be able to measure and test it, and it should be based on evidence. If you were overwhelmed by the 83 theories in the ABC book, you can instead rely on the COM-B model, also by Mickey and colleagues. In the model, behavior is the product of three factors that are all regarded as necessary: capability, opportunity, and motivation. That's the green inner circle in this behavior change wheel. The outer layers describe intervention functions and policy categories. Instead of one theory, you could also look for theoretical domains, constructs shared by many different theories that will help you to understand what the key determinants are in your case that need to be addressed. For example, maybe it's not a question of poor knowledge, but rather low confidence or self-efficacy in your target group, or lack of environmental resources, or both. Some benefits of the framework are that it covers different potential means of influence, and it makes a distinction between different types of influence. And I will show in a minute how it links behavior change theories to behavior change techniques. You can find a more detailed description on how to use the theoretical domains framework to investigate implementation problems in this article. Once you know your determinants, you can get guidance on techniques that will help you to change them. In the GOAL program, we based our intervention targeting participants' lifestyle on the Health Action Process Approach, or HAPA model. Based on this model, we assumed that participants would be motivated to change their behavior if they perceived their risk for diabetes to be high, if they expected positive outcomes for the change, and also were confident in their ability to change. We targeted these determinants with information about participants' personal risk and diabetes, the benefits of lifestyle change in preventing the disease, and for example, with reviewing past success and mental rehearsal. Then we used techniques to address the planning and action phases of this model. If you were using the theoretical domains framework, you could also easily link that with the behavior change techniques. So, for example, if your needs assessment found low self-efficacy as one of the key determinants to address in your intervention, you could use verbal persuasion, mental rehearsal, focus on past success, or self-talk as the behavior change techniques. Or, if you found environmental context and resources as barriers, you could, for example, think of ways to restructure the environment. I think behavioral sciences have put too much emphasis on cognitive and reflective processes of change, such as self-beliefs, and too little on automatic processes that are typically triggered by the environment or context. So let's take a look at those briefly. Choice architecture and nudging rely on automatic processes. They have been used in marketing for a long time already, and increasingly also in changing people's health behaviors. My slides on this topic come from one of my current PhD students, Eva Rantala, who is conducting a study to implement choice architecture interventions at work sites. According to Thaler and Sunstein, who wrote the famous book called The Nudge, choice architecture refers to the way in which available choice options are arranged and presented. And a nudge is any aspect of the choice architecture that alters people's behavior in a predictable way. However, a nudge does not forbid any options or change economic incentives. It is easy and cheap to avoid. So, although people are not necessarily conscious about the choices or putting effort into the choices they are making due to a nudge, they are not opposing them either. Here are some specific aspects of choice architecture related to food environment. You can probably identify ways that they've been used in your own context to influence your unconscious choices. Even the most effective interventions will not be sustained and systematically used in routine practice unless organizations and professionals are willing to implement them. Normalization process theory proposes a set of preconditions for adoption and sustained implementation of any novel practice. First of all, changing the practice has to make sense, and there needs to be a feeling of win-win on all levels involved. Second, cognitive participation is needed from all parties, meaning not just engagement but also actual ownership and willingness to advocate. Collective action is required to make it work, and that requires clear roles and responsibilities. If new skills and capabilities are needed, there needs to be sufficient training and capacity building. Finally, the practice should not be forgotten or quietly terminated, but monitored reflexively with opportunities taken for learning and further development. Promoting this process with an intervention could utilize, for example, the plan, do, study, act cycles in workshops that would bring together all relevant levels such as organization, implementer, and patient. The NPT website provides tools and resources, so that's also a good site to visit. Just to remind you that you cannot carry out implementation research without active partnerships with your stakeholders. When planning your stakeholder collaboration, I suggest you use the same systematic approach and theoretical thinking as in other areas of your intervention to guarantee that your partnerships actually go right. Finally, if you are using a planning framework such as the intervention mapping, record the output of these steps into your planning matrices. Now, for the last part of this lecture, let's look at the third function of theories, models, and frameworks, which is to guide comprehensive evaluation, covering both effectiveness outcomes as well as implementation outcomes. If you used intervention mapping for planning your project. Each step has informed you on what to evaluate. Behavior change in your target group, change on any other significant levels, determinant change, as well as adoption and implementation. But it's also helpful to use a specific evaluation framework. One of the most frequently used evaluation frameworks in this field is the RE-AIM. You can see that it could also serve a double function because of course you want to plan your study with your outcomes in mind. Here, while all the factors are important, I want to emphasize the importance of REACH, especially in terms of your public health impact. In the RE-AIM, public health impact score is calculated as a product of all the factors. Hence, even with a small to medium effect intervention, the public health impact will be considerable if the REACH is high. So maximizing your REACH will bring much better return on investment than maximizing the impact of the intervention on only a few people. Hence, not only the penetration in your target population, but also willingness to participate are crucial. Same as with partnerships, it will pay off to plan your recruitment efforts with the same rigorous and systematic approach and theoretical thinking as other components of your intervention. I've also added some other considerations or reminders that I find important, such as measuring maintenance on all levels. I mentioned the importance of participants' willingness to participate in your intervention, and not just to sign in, but to really engage. This theoretical framework of acceptability gives you an idea of what this multifaceted construct may contain. I think it's equally useful to consider on the implementer level, not just the participant level. For assessing your intervention outcomes and interpreting your results, it's important to know whether the intervention was implemented as planned. This is called the fidelity of implementation. Similarly to other areas of behavior change interventions, the science on how to promote and measure fidelity is rapidly progressing. With low fidelity, you cannot expect effectiveness in changing behaviors or their determinants. This flower slide also comes from Eva Rantala and her study on implementing choice architecture intervention at work sites. She is adapting a model by Virenga to look at factors that influence quality of implementation related to the intervention, as well as to implementer, organization, and wider socio-political context. The theory you selected to identify determinants that your intervention then addressed will directly guide evaluation of how successful the intervention was in changing the determinants or mediators. Here is an example from a former PhD student of mine, Nelli Hankonen, who evaluated the goal lifestyle intervention. She showed that the intervention was able to strengthen participant self-efficacy and increase planning with social support impacting both. And these changes helped the participants to increase exercise. And my final example is from the Normalization Process Theory website. The website provides you also with questionnaire items to evaluate the normalization process. I've collected all the main resources that I referred to during this lecture on this page, and I really encourage you to go and visit the sites. I also hope that you will come to the plenary session with a lot of questions and comments on this talk. I hope I have not overwhelmed you too much with this talk, but instead managed to convey my main message, which is that in implementation research, you will need theories, models, and frameworks to keep you on track. But there's plenty to choose from, and it's okay to make pragmatic choices to optimize fit with your context and your objectives. And finally, there are all these great resources that you can use. Thank you for bearing with me.